Good morning, good afternoon, and good evening to our global audience. My name is Dr. Dipu Patel, and it is my honor and pleasure to welcome Dr. Elena Rokou, who is an adjunct professor of operations research at Pitt Business and chief research officer. She's also part of a nonprofit called Creative Decision Foundation. And from fusing AI agents to optimization and analytics to tackle complex decisions in health systems, research workflows, and beyond, Elena brings the analytic hierarchy process and the analytic network process to large language model projects, teaching, and global hackathons. Welcome, Elena. We're so delighted to have you.
I am honored to be with you and looking forward to our discussion. Thank you so much for having me.
Thank you for being here. Well, we're going to dive right in because today we're talking about how to actually tackle AI agents in the health innovation dilemmas that we often face. And you are the person to help us kind of navigate this landscape as it is evolving and shifting almost on a daily basis, I would say. So let's dive right into our first question. When people hear AI agents can simulate health innovation rollouts, it sounds like magic or almost impossible. What actually is happening under the hood?
With the fear of disappointing you, there are no wands or magic involved in the process. Lots of math, however.
Lots of math. That's what I tell my kids. Yes. Learn the math. It's important.
Which is some kind of magic, or at least that's what I say to my daughter. So we're talking about agent-based simulations, and I'll tell you the deep down truth. When we are talking about AI agents and simulation, what we are trying to do is, instead of spending millions to make mistakes in real life, to spend millions of CPU cycles on a computer system to make error mistakes. It's not that we have systems that don't have issues or there aren't conks to be straightened out. It's just that we move the place that we try and make mistakes from an actual real life situation to a digital sandbox. And that's the whole idea. Unfortunately, like in real life, whatever, we have to be very careful to collect correct data, to try to describe the situation with all the details that we can, because if we miss one of the aspects of the problem, we are missing something that will end up facing in real life. So it still has some risks, the whole process.
That's really interesting. And you're absolutely right. I think what you're getting to the heart of, Elena, is the data and the clinical aspects of what you do are really, really important. And agents can only do or execute on functions when they're given the exact commands or tasks that they need to execute on. And so when we look at things, there are lots, as you alluded to, it's a safe place to kind of fail fast forward, right? Without having a patient life at risk or even other projects that may impact patient lives. When we look at these pilots, then there are many promising pilots. They tend not to do well when they're being scaled. So how can agent-based simulations help innovators spot scaling risks before they commit the resources? So, because to your point, it's not the patients, we're committing some CPUs. And that still is still time and energy that we're putting into these pilots. And we want to make sure they are successful and can scale.
That's really an interesting question. Most simulation actually tackle three big types of risk. Horizontal risk, for example, will your urban ER work in rural situations? Will you have the same situation? And it depends on us, on the way that we collect and feed the data. Will we remember to collect data and feed the system data from different locations with different socioeconomical backgrounds, different infrastructure, in order to be able to see how the horizontal simulation will work out as we expand? Then there is the vertical component of the risk. It works well with 30 users. What will happen when we'll have 30,000 concurrent users trying to check their blood test results on a Monday morning? Will it work? Will it crash? Or will it be somewhere in between? Which is something that the simulation can easily show you. So that's something that it's kind of designed for an AI diagnostic tool. It's something that easily can tell you quickly without you having to go through the actual real life pain of it. And then there is, I would say, the most promising, but also the harder to implement, that is how to describe the ecosystem as a whole. It's more challenging to be able to create something that is meaningful and useful, but it's also what we all are trying to find solutions, because it's the solution of tomorrow. It's the answer that we are looking. How can we create ecosystems that show how the hospitals will resist, for example, to budget shifts, how different groups of doctors or nurses or even of patients will react to different changes? Because one change at a time, even my old school math says, I can easily predict one change at a time and how it will affect the system. However, what happens when I have 10 changes at a time? And some of them can also, work together or against each other. And we are trying to use the AI systems just because they have all that complexity, which is under the hood, covered for the user, as a means to create an ecosystem, our own personal, let's say, crystal ball that will help us feed data and get possible results. We do understand that we will not have a single solution. Hey, if you do that, this is the solution that you will get. But it would be nice to have 10, 20 different possible scenarios and the probabilities that go close.
That makes absolute sense. And that actually takes me to the next question, which is, as we look at the scaling risks that you've just mentioned, in practical terms, how do these simulators model patient, clinician, or system adoption? Are there certain inputs that matter more for accuracy or precision than others? And I guess as a clinician, I would say they all matter, so they're all important. But from a systems perspective, what's your take on that?
As a computer scientist, I would say that even the tiniest detail can throw away a system. So give me everything that you can. However, I would say that there are some inputs that are a little bit more needed than others. For example, how can you describe the patients? Because we are talking about health systems. What is the level of digital literacy? Or what are the healthcare touch points, social influences that they have? Maybe if they have a specific cognitive load tolerance, the more you have to go through a specific process, the less tolerant you are in changes and having to create a new process in your life to make space, even for a fun, good app that would help you. So all of these are things, not that we don't want, we just need to know in order to predict the best way to handle the situation. Or there might be specific features that would help those groups to adopt cleaner and earlier a product if we knew that they are there. Similarly, for the side of the clinicians, it's good to know their workload profile. It might seem unrelated, but a workload profile is important in adopting a new technology. Or what is their workflow complexity? If they are doing already 40 different steps and I'm adding another 5 steps in their process, obviously they will not welcome the same way with another physician that has only 5 steps in their workflow. And they are very willing to adopt a new technology because they have space and time and they are relaxed and welcoming the change.
Right.
So, and also the risk profiles, meaning, will it improve the way that they do their job? Will it make it less stressful, or will it make it more stressful by bringing in more mistakes, possible mistakes? Because it happens, it's a new technology. When you bring a new process, not necessarily even a new app, a new process, it might bring mistakes at the beginning. Is it a system that can handle a little bit of extra load, or is it already at its threshold? And the last part is kind of systemic. What are the budget cycles? What are the regulations? A big part that we sometimes forget when we try to scale a system is that regulations might be different from location to location. Even within a country, let's not discuss about when we are going internationally or globally.
Conversation, Elena. Let's not talk regulations. It's a whole other conversation.
All by itself, imagine how you can scale or discuss about a system that should be able to follow regulations that are different in each area and make all these systems communicate. So yes, I need a large model that will help me navigate all that, because there is only so much information that a group of humans can handle. I need the assistance, as long as we can still feed them with good information and know the limitations of those systems. I'm not sure. I think that's kind of all. It's a balance between the two.
Absolutely. Actually, a balance between 3, because patient, clinician, yes, but the system has to be able to handle the workload.
Yes.
Furthermore, the infrastructure that the system has needs to be currently able to use, or at least help with the new models and systems that you're trying to put on it. A lot of times, hospital systems have outdated infrastructure, which doesn't allow building or reiterating on the newer technology that we're trying to implement. And so sometimes it's not that you don't want to bring in AI or an agentic AI into your systems. It's that your infrastructure just won't let you, and you need to kind of go back and either start from scratch, build a new infrastructure or a new platform, or find something that's a little compatible so that you can then start building these new agents to move yourself forward. And so that brings me to, I guess, the question that I had, and this can be for startups or hospitals at large institutions, which is, how can simulations shift decision-making in research and development, especially when funding at this time is really tight? And that's not true just for the US markets, but also globally.
I think that, and it is a thing, because remember that although AI agents were not around a long time, simulation models are around a long time. Yes, simulation's
been around since the 50s and 60s. Yeah, exactly.
And it's not always used, or we don't always love the results that we get from a simulation. So assuming that we would like to adopt the results that we get, there are some positives, both for startups and hospitals. You could prioritize features in order to see what should be the first thing that you will spend your money on, depending on how the model shows that this will be adopted. So things that you expect that will be quickly adopted right now, so it's the right time with the right you have the right time, the right people, you prioritize it, and things that the community, the system is not mature yet to receive, you leave them for later on. So that's a scheduling, resource allocation, essentially, decision. And that leads to optimizing also market timing. So sequencing different products based on the fact that you see which product requires which other product in order to be able to exploit the market and go and give the 100%. And from the side of the hospitals, I think there are quite a few hospitals that are trying to go that way, to design pilots in order to see what will be the maximization of return, not necessarily in a time setup or a cost setup, but also in value. So you can see different plans where the priority of time, cost, quality of the product is different. And you're not spending money while you're simulating all these systems. So you can end up having 5 or 10 different mix of solutions. Let's say when my priority is by 70%, the return on my investment, but by 30%, the next priority is the extension of quality of life. Or when my priority is innovation by 40%. And you can see each time, each decision, how will affect the portfolio of products that you will be choosing and going for. And kind of the same for the staffing decisions, meaning depending on how you are planning the next 15, 20 years, you can see how you can strategically start building units and groups. If you know that you are rolling out unit A in 10 years, you'll start getting people that as they grow and improve, they will be already part of your personnel instead of trying to acquire them when they are already there.
Oh, right. Yes.
So there are a lot of strategic decisions that you can
I was
do.
about to say, strategic growth is one of the hardest things to get right when you're, especially when you're trying to scale a solution, because if you're too early to market, people aren't going to adopt. If you're too late, it's been there, done that kind of thing. And so you have to be able to time the market, but also time the solution and the need, and then grow with it as you develop and evolve the product. Which brings me to the next question, which is the environmental aspects of growth. So scaling a health tech solution in the US is one thing, but doing it in low resource settings is a completely different ball of wax, right? So how can simulations account for these vastly different market realities? I think you started touching upon some of these examples, Elena, but like we have a pretty global audience here. And so many of whom come from pretty low resourced areas or practice in rural areas. How do we go about thinking about simulations and helping these low resource areas scale some of these solutions?
I think that's the very short answer, and we'll elaborate on that, is data. Really data, nothing more than that. And that's where it comes also John Lee's scalability theory, because it works exactly on that point. Right. And I'll tell you what I mean. There are some specific barriers to implementing in a general community. Think of it like there was a team at a university that developed a medical scanning application that you could use your phone to scan your screen and get back a very good monitoring for skin situations. And they actually try to elaborate and use it in different parts over the world. They hadn't taken into consideration that the quality of cameras in different parts of the world would be different. So not everybody would have the iPhone that they were experimenting with. And that changed by a lot the way that the system would work, because yes, they were using a generative AI system behind the scenes to recognize and do all the fancy stuff, but they had to train it with different type of data in order to be able to react to different types and qualities of images. So the challenge is to be able to think outside of the box and cover as many different types of situations. The positive is that even if you kind of mess up, you can add the data as you go. It is forgiving like that. So if I, by mistake, exclude a group or a type of data, I can go back and improve my set. It is a trial and error at some level. If I know from beforehand where I'm going to expand, it's easier to request data from different locations and make sure that I'm covering that. But if I don't, it will make it a little bit harder. I mean, I want to say that we all take into consideration that we are collecting data with the most heterogeneity and general data that we can, but it's always so hard to cover all the situations. I prefer to say, be prepared to discover the mistakes and go back, retrace your step, and improve your data sets. So that's one
so
of the barriers there.
That's a great
And then
example.
there is also a selection bias in the training and testing, meaning that, especially in the medical field, we have kind of a training of selecting the most promising data to test new ideas.
Well, we want it to work, Elena. We want it to show us the results we want.
Believe me, my computer is the best that you could have because it has to be fast application. I fully get it. However, we have to go back and fix that when we are doing an AI agent. And it is kind of something that you have to learn to recognize it with that, because it's something that comes natural. There have been years and years that we learned that we'll find the exams that are the most likely to succeed. And now I'm asking you to give me exams that they are not going to succeed, because I won't be able to do a good simulation if you give me only the ones that are likely to succeed. And it's so hard, but it is one of the barriers. So that selection bias in the training, it's something that we are working all together and trying to learn what is kind of the mix that has the good and bad together to give a fair group of training data.
That's, you bring up a good point about selection bias, because a lot of times as we're conceptualizing a project, we'll end up, we have the solution in mind rather than starting with a goal. We aim towards a solution. And I think it's one of the things with simulations is that the numbers and the data aren't going to lie unless you have cherry picked the data for the solution that you want, right? And we see that pretty often in small projects within hospitals around quality improvement projects or little cycles that folks run. But at the scale that you're speaking of, it really does matter. And we need true, honest data to help us turn the raw data into real world insights that can be applicable and turn into an actionable strategy. So I guess my next question would be, if your model's data is flawed or incomplete, perhaps maybe that's a better word, your simulation could lead you astray. And so what are the safeguards or validation steps that you think are essential when you're looking at a model set, especially when model sets are so large in the space that you're working in?
I think that it is kind of a technique that we use a lot on optimization, and I believe that works also for general simulations, which is create a set of generated data that represents specific situations that you know that exist, and always benchmark your solutions against those data. If the solution can cover all those sets, and I would say, very good infrastructure, everything goes well, is data set A, to the worst possible case that is test case 10. I have those. Nobody gave them. They are not actual patients. They are inspired by, but generated in such a
Yeah.
way that if I made a mistake with the real data, I have also a fallback plan that might flag me that I am doing something wrong in the selection of data. It won't be enough to correct the problem, but it will be enough to lead me to reevaluate the data that I used. And I think that
That's very helpful.
as we gain experience, we will have actual data that we can use for that purpose. We will create systems that we can use as benchmarking for our models in order to make sure that, hey, this is the benchmark for medical applications, or this is the benchmark for whatever other kind of application.
And I guess I'll ask in my naivete, Elena, those benchmarks don't currently exist, right? We're still trying to figure those out.
I think that we don't have at this point of time something that I know that is generally accepted by everybody for all specific applications.
Okay, that's very helpful. So in the future, I guess, do you see a future where simulation tools are embedded into everyday workflows, almost like another team member, in either in a clinical setting or in a business strategy setting?
I think that in the next 5 years, probably you will think of all these LLM and esoteric AI agents as you think now of Google search. Just that. I open my browser, I do a Google search, will be that same familiarity and ease of use because it is that simple. As long as someone expands and connects the different components, it's not something really hard. The work is in collecting data, which is not the job that we would mostly do.
Right.
Most people
It's probably
will
the
be
unsexiest
looking
job.
for, yes,
Yeah,
most people will be looking for answers. We will not be collecting the data or
collecting.
cleaning up the
Yeah,
data, as we don't do with Google, right? Nobody
right.
does.
It truly is the unsexiest part of all of this that we do.
So yes, I think that in 3 to 5 years, the large systems will have innovation simulation as part of the system. We won't even notice most of the times that it exists. It will be just another tool in our set of tools.
In our set of tools.
Yeah,
That's
like,
very interesting. So as we're rounding out here, my one of my last questions before we go to some questions from our audience is looking ahead, what role will simulation driven innovation play in healthcare transformation globally? Could it become a standard step before any major rollout? I think you alluded to that in 3 to 5 years. That's what you're thinking.
I think that maybe by 2027, we have still kind of the early adopter. So you see it in systems, but it is not a protocol or a standard. I would expect that maybe by 2030, we might be surprised to be part of the necessary protocols that we follow. So in order to roll out or to accept maybe a clinical trial for a drug, you will
Yep.
have to submit also the simulation results and how it looks for the next 10, 20, 30 years, depending on the type of drug. So, and after 2030, I would say that if everything goes okay, it will be, a standard inside all the analysis that we do. The same way that right now we do general, I don't know, return on investment,
Right.
like that. That
Yeah.
would be part of our analysis, a very standard part of our modeling and analysis of models.
I would also argue that it would also be part of regulatory approval of these processes, right? To show that this works in
Yeah.
a simulation and getting us one step closer to precision medicine and personalized medicine as we're um, uh, using these simulations to really prove our point, so to speak, or prove the product, so to speak. And by the way, 2027 is not that far away, and
It
neither
is
is
2 years,
2030.
yes.
I know, 2 years away.
It's
So,
2 years.
all the tinkerers in the world, let's get started. There's
Yeah,
lots
I
to
think that
do.
you're right. At some point, it should probably be part of the regulatory process. I mean, it makes sense that it will go there as
So,
long as we have trust.
as long as we have trust. No, I completely agree. And I will say for our audience, what we are not touching on is the ethics and the trust and the transparency piece of it, which of course I think goes almost without saying, but is no less important, even though it's not part of the discussion we're having today. So we have a couple questions from our audience before we close out for today. The first question is, how can AI agents be trained to navigate conflicting priorities between clinical outcomes, cost effectiveness, and scalability? That's an excellent question.
Excellent question. And I would say I don't see them needing to be trained. I would refer to the group of decision makers that is handling the decision and request from them the basic priorities. So give me what is your mission, what is your goal, and what are the priorities that you want for the simulation scenario that we are working. So I can give you a simulation scenario where you prioritize clinical outcomes by 10% versus cost effectiveness and scalability, and another scenario where I do a different prioritization, always based, however, on the decision makers, because that is
Right.
a decision that goes to humans. It's not something to be simulated.
Right. I almost answered it before I let you answer, which is you can't, because this is the human in the loop component of what we're talking about, right? So
Yeah.
really AI agents shouldn't be trained fully to navigate conflicting priorities. That's our job as human beings, to be that check, because in some instances, the cost effectiveness may not be the thing that we want the agent to take into consideration. It may not be the top 10 things, variables that we wanted to take into consideration. But the clinical outcome may be the most important thing, and that's up to us to decide as the developers and the decision makers. So second question, if AI agents could self-learn from global health innovation data, what safeguards would be essential to ensuring unbiased ethical recommendations? And this touches on the last point that we were.
I'm afraid that I will refer to humans again. I don't
Yeah.
see AI to be able to have a heart or soul, and I'm not expecting that they will get one soon. I'm expecting that the humans that are part of the loop will be adding that component in any decision. So the safeguard comes from the humans that are part of the decision making process. The requirements, which might be different from group to group, will come again from those groups. Uh, they can be translated to rules in an AI system always, but someone has to decide what are the rules that you want in that specific system. Someone has to take kind of that responsibility. I don't think that a bunch of lines of code can do that. Essentially, it is more of our responsibility to decide what is very important, a little bit less important, and what is not so important in that specific time frame and context.
I would agree with that, Elena, because at the end of the day, no matter how much quote unquote thinking these agents will do or simulate for us, the they are tools that need to be to have some bumpers and safeguards around them, and only we as human beings can ultimately make those rules and decisions for whatever clinical outcome we're looking at, or scalability, because to your point, it's not actually it's a machine, it's a tool. It doesn't have a heart, it doesn't have a brain, even though we like to use very human terms to describe these agents. They are not, and I think they're so good at what they do that we often forget that they are just tools that we are leveraging for various purposes. So I would absolutely agree with you. Well, any last words before we wrap up?
I really, really am looking forward to see the next in the next 10 years these interviews by an AI and both of us being the interviewed.
Yes, my avatar will welcome you anytime, Elena.
I'll send my avatar next time.
Thank you. Well, to
Thank
our
you.
audience, we hope you have enjoyed this conversation with Dr. Elena Rokou. I do want to give a big quick plug to our Doctors AI Global Summit that will take place in November 15th and 16th. So if you are able to join, we are meeting live in Bangalore, and we'd love to see you there. So thank you, and that's a wrap.